I think you guys know who rules roost in mine.
Okay. Good afternoon, everybody. Welcome to Social Services Budget Committee. We have one topic, and it's a presentation from Secretary Stanek from KDHE. Before I do that, though, I would be remiss if I didn't follow my Francie instructions. She said, well, we've been talking about not next week, but the following week. She is working on setting up a tour of the KDHE laboratory on Tuesday the 24th, and we have Tom Tracy from the Treasurer's Office scheduled to be here on the 26th to give an ABLE account informational hearing, and Sarah Hart-Weir and team may be here that day as well. So anyway, that's next week. As everybody knows, we are going to be on the floor pretty much all week, but while we're here and in session, have time to take advantage of the resources that we work with. I think it's great. The tour yesterday at K&I was a good thing. In fact, so much so that we're trying to figure out a way to get at least a handful of people who would like to go to Parsons before we conclude. Don't know how it's going to work out, but we're gonna give it a shot. Okay, so with that, I know that's all we need. That's all right. So without further ado, we have Secretary Janet standing here from KDHE, and the topic is the Kansas Rural Health Transformation Plan. I've heard this, I'm excited to hear about it. We heard it in Bethel Committee and other words. So I think this is a really cool opportunity for the state of Kansas. So Secretary, it's up to you.
There. Okay. Hi, Janet Stanek, Secretary KDHE. Some of you have heard a little bit about this program. So I hope, I'm not sure, do they have the fact sheet? Okay, so you have a fact sheet and an outline, kind of gives the high level, but Kansas was the recipient of this grant. I'll go to the PowerPoint that I hope you have in front of you. This is the result of H.R. 1, or the Big Beautiful Bill Act, by the federal government. We've been working on this nonstop since July because it was a very rapid turnaround bill. Fast forward, this is a result of cuts that were made to the federal Medicaid program, and so this was like what the government threw back that we could do to help rural America. So I will say not rural hospitals only, it's the Rural Health Transformation Plan, which includes all kinds of people that deliver health care. So we were awarded, we were all told to budget by CMS for $200 million. So this is a year-by-year, 5-year application. And we got $221 million, so we got way more than we thought. And that's due to several things. Part of it is our makeup, our rurality, so to speak. Some of it's due to already regulations and policies and statutes we have in place that are favorable to the MAHA agenda at the federal level, compacts for providers to cross state lines, et cetera. And then the rest of it was our strong application that we put together. So this is not a lump sum payment. It's a drawdown of federal funds for expenditures included in the budget that we submitted with the plan. And then our ongoing progress, and we have a very stringent reporting requirement with CMS to report progress on a regular basis, demonstrate we're using the money like we said, that we're showing the outcomes that we put in the plan, et cetera. That allows us to continue to get continued funding the next year, and that's again for 5 years. On page 3, you'll see what our high-level plan initiatives were. Expanding primary and secondary prevention programs, securing local access, local being key there to primary care, building a sustainable rural health workforce, enabling value-based care, and that's basically pay-for-performance initiatives. That includes trying to put things in place that will help improve health outcomes, standardized care delivery, et cetera, and that can get you more money to your bottom line, therefore helping rural institutions stay afloat, and then harnessing data and technology. There are a multitude of initiatives under each of those. So I was just asked by the chair, for example, where mental health, behavioral health falls. It could be found in any one of these. You're going to see a large list of those items. So This is, again, about transforming the delivery system, and it's also very focused on sustainability. There are a lot of restrictions. I won't read them all on page 4, but you can see how stringent the requirements were. We had a lot of requests to thinking initially, this was like, great, I'm going to get a check to help me sustain my organization. And I don't say that in any kind of ill-will manner. It's just, this is not what that was for. So you can see that you can't pay for services that are already for clinicians that are already reimbursed another way through insurance, for example, or through Medicaid. You can't purchase food, even though we have a pretty large initiative for food as medicine, and which was very favorable to CMS. You can work on replacing your electronic health record, but it's capped at 5%, and the list goes on. So a lot of the success of this grant, from my perspective, will be on how we execute it and govern it. And you all, of course, play a role in that as well. So on page 5, the governor initially designated oh, excuse me, I went too far. Oh. I'm too fast with this. There, the lead agency to be KDHE. The money goes to the governor. She has to designate this to a state agency. It cannot be done, given out to a third party. It has to be an agency of the state. There was an alliance formed of all our stakeholders. You know, we can't do it alone, and we have so many great partners that are doing great work. So we call it the KRIA, the Kansas Rural Health Innovation Alliance, to facilitate stakeholder meetings and give us feedback on the program. And we got a lot of feedback ahead of that, even before, from a lot of stakeholders to fill the application out. We also are partnering with our friends at the CARE Collaborative, which is part of the University of Kansas, to help us with project coordination, and that's gone from management to coordination and assistance since we've written this. They have a decade of experience working with providers in the rural area, working on value-based care, heart and stroke initiatives, a lot of what you talk about, Chairman. And they already have, there are 91 provider organizations across 79 counties, including hospitals in 72 of the 79, or excuse me, rural Kansas areas, 75, along with the affiliated clinics, and so forth. So we have to adhere to what CMS's timeline is and all of their requirements, and I'll talk about that in a minute, because we've just gotten further on that process since we've last talked. On page 6, you will see a list of the KRIA members. Very valuable, no stranger to any of you, and you're not a stranger to any of them. The organizational chart there shows where the governor sits. KDADS, my peer, Secretary Howard, also plays a big role in this. They're our sister agency that's partnering. I'm what's known as the authorized organizational representative. That's a CMS term. And then Matt Lauer, my chief of staff, has been promoted to be the director. So this will reside in the office of the secretary. This will not be another bureau or down in Medicaid. It needs that prominence, and I hope that's where it stays. Not because anybody can't do it, but it needs that focus from CMS. And I think that worked out really well so far. And we, again, are coordinating with the CARE Collaborative from the University of Kansas. And then we already have an Office of Rural Health in KDHE that is pretty much funded by CMS, so some of this will crisscross there as well. We go into more detail on page 8 and 9. You can see what those value-based incentive programs are to help get clinics and providers who haven't been able to participate in collecting quality metrics and things like that to try to get more to their bottom line and show better outcomes and avoid ER visits and all the stuff that comes with better care. Trying to get the infrastructure for them set up and provide technical assistance, for example. There will be a fund of, for year one of $44 million where all regional partnership and capital investments, so $44 million for regional partnerships, where once we get the green light and get the money, which we think we'll get next week based on a call we had today, that we have access to the money, people will be able to apply for grant money, and they have a $44 million pool we'll be managing to say, this is my project, here's where it fits with and aligns with the plan for Kansas, et cetera. There's also a $15 million capital investment for year one, where people will also be able to apply for capital investments as well. Number three, we're going to expand, and I might note this, and then the governor also emphasizes, we do so many good things right now and have so many programs across the state for healthcare delivery, in whether it's long-term care, behavioral care, acute care. Let's leverage those and expand upon and be able to promote them further into the rural areas rather than start with 15 new ideas that we don't even know are going to work. And there'll be new ideas, but leveraging existing ideas is also a mantra or a principle of this plan, basically, a pillar, so to speak. So community health workers, we have a very robust training program in KDHE that's been in place for probably 8 years. There's a certification program. One of our very favorable by CMS programs that we're going to roll out is accountable food as medicine, where we expand upon the community health workers in the rural areas to help people with the food as medicine and the tie to medicine. It's not just giving them food in a basket. It's the whole continuum. So we're very excited about that. Workforce development. You can see number 4, that will start from K to 12. It's not just like residents or anything like that. This includes getting maybe people certified to be a CNA. It could be providing support and training programs for any kind of level of care, EMS, et cetera. There's also an Anchor Hospital Advancement Program. This will be led by University of Kansas and Ascension Via Christi. This is basically in an effort, and again, going back to CMS's principles on this and what the requirements are, keeping care local and in the rural areas is something they really want done. They want you to recruit and place physicians to live. They don't want roving physicians, for example, or roving clinics. They want to see a sustainable workforce. It's going to be difficult, no doubt, but they're giving you money to do it and come up and be creative and whatever. So the Anchor Hospital, this will include, yes.
I have a question.
Pays has a
Oh, sorry.
Yeah,
I didn't know, sorry.
that's okay.
Going on.
If it's all right, I would like to ask a quick question. So you talk about physicians. What about advanced practice providers, or is it physician specific?
No, it's all levels. It's PAs, it's dentists, it's everybody. No.
Okay, thank you.
No, they are included, yes. So thanks for bringing that up, yes. The Anchor Hospital concept is one where there are some mid-range hospitals, for example, that might get transfers in from smaller hospitals in their region, but also those smaller hospitals might want to go to a Stormont Vale or a KU or an Ascension Via Christi because they don't have the resources. The idea behind the Anchor Hospital is for the medium range or the mid-range to be resourced better and trained better to handle those, so we can keep people closer to home and not everything will be a life flight or an ambulance ride into Kansas City, for example. So the idea behind that is really about keeping care close to home, but providing quality care. So this immediate next steps, some of this has taken place. So we showed you, we have complete in process, et cetera. This just is an outline of where we're at. I'll fast forward to say that our infrastructure is set up. We've got committee meetings and committee structure set up. We have an executive committee. We have an interstate committee, which is KDADS, KDHE, the governor's office, and KU, the Care Collaborative. And then we have the advisory committee, which I talked about. And that's where a lot of every week decisions are being made and feedback and communication are happening. Right now, we've had as of January 30th, we submitted our budget revisions. We got approved for the $221 million, but there were revisions we had to make. We had to be more specific on certain things and whatnot. Submitted that, got a note this week. You got 3 things to fix. We had to recategorize a couple of the programs. We couldn't call something a scholarship, for example. We had to call it an education and enhancement program, something like that. So we're fixing those. Those will go in by the end of the week. All we have to do is submit a budget note. And we believe by next week, we hope to excitedly be able to say we got the money accessible to us. And This is going to be a lot of challenging but fun. It's going to be great for Kansas, and we really want to help our partners and help the state with this. On page 11, there's a timeline, and it shows, starting back in December, where we got the notice of award. And I just talked about our budget and our budget revision and so forth. If you go further to July 31st, so here we are, February 11th today. We don't even have access to distribute the money yet, hoping to next week. Starting to get it out the door or committed to, basically, and allocated. We have to start reporting on the program by July 31st. That's when our first report is due to say, here's how we're doing. So we have a very short window to demonstrate progress on some of the initiatives. By October 30th, we have to demonstrate that we allocated that $221 million, not spent it, but allocated it, and where it's going and what programs, et cetera, and continue to report on those. And by October 31st, the next application for funding for year 2 starts. So this is a very fast-moving train. I say that just to demonstrate why we haven't had a lot of time for, lots of strategic planning discussions or anything. We've done it, but it's been very rapid. And then by September 30th of 27, we have to spend that $221 million. That's the year 1 money. So we have until next year. It'll go into like a year and a half to spend, basically. If we don't spend it, then that's when they review and take back. And then they decide if you apply for year 2, for example, maybe you don't get as much. I'd like to get off the PowerPoint if that's okay and just talk a little bit. They're very flexible. CMS has been very flexible. They're demonstrating they are partnering, they want to help. We will have calls, and we had our first one with our official project manager today, for every 2 weeks, no less than a month, but we're going to take it up on every 2 weeks. If we have questions, there's direct emails. They've been quick to turn around to get clarity, to make sure we're doing everything right. We're sitting on numerous WebExes about how you report on this grant. There's a mandatory meeting in Maryland at CMS headquarters coming up that we have to send people to learn more about it, and you have to attend. So they have a lot also of skin in the game on this. And I say it's good and bad to be first, right? This is a first opportunity, but I think they're very willing to help and to let states guide how this will go, and they'll amend it along the way. So we can talk about 5 years out. You know all that, right? You're going to see the plan. That plan's going to be amended like any strategic plan. However, we'll do it in collaboration and in conjunction with them, and they'll help us so that we can continue to keep that money for the state of Kansas and leverage this opportunity. So I'll stop there because I know you have the fact sheet, and I'll entertain questions unless you want me to continue to go on about the program. Thank you.
I know I've got questions. I want to hold mine for now. Representative King?
Thank you, Mr. Chair. Thank you, Secretary. 221 million first year. Any anticipation for year 2 funding? If it'll be more or less the same? Any idea?
Our goal will be to get the same. Okay. At least the same. And, we're number 6 in the country, and we don't count California and Alaska because they're so rural, right? But we did well, and so I think it's safe to say someone would really have to be sleeping on the job to not get that again, because unless CMS pulls something, I'll put that. But I think if we stay true to staying in touch with CMS and understanding what they want and them helping us and them guiding us, we should be able to get that 221, in my opinion, yes.
2 more quick questions.
Sure, go ahead.
Slide 9, number 6, it's your 6 priority programs. The last one was the Anchor Hospital Advancement Program. You mentioned Via Christi Ascension, KU. Do you foresee something like a Colby being a anchor hospital for the 6-8 counties around that area? Or are you seeing it being one of the really large ones?
No, it's not. Actually, I'll just clarify, KU and VIA aren't anchors. And neither would a Stormont Vale be. Salina might be an anchor, for example. There's criteria that have been developed. I can't speak to Kobe, but I'm almost thinking yes, because they're large enough to do. And I would also point this out, that for hospitals or healthcare organizations that are not rural, if they put in even to that fund to apply for some of that 44 million to say we have a project, they have to demonstrate that it's going to, and how it's going to impact rural, first of all, and it cannot have an impact on their bottom line. It's not about making their bottom line better. It's about making rural health better. So CMS has built that requirement in there as well. Just, I wanted to make sure you knew that.
And then my last question, if I may, please. On page 10, excuse me, the top item, submit updated budget to CMS. Is that available to us, or I'm not sure I have seen that total budget or expenditure of the 221 million?
We can get it, it's on our website. So there's a link in this document, but we can also make sure that you get the link. We have a dedicated page for the RHTP. We call it Rural Health Transformation Plan. And if you click on the application, all of that information will show up of what's been budgeted and whatnot. Now, the revisions, I need to check on that. I think we've decided we're going to post everything because it's public knowledge anyways. It's public information, so, yes.
Thank you, Secretary. Thank you, Mr. Chair.
Representative Carpenter?
Thank you, Mr. Chair, and thank you, Madam Secretary, for being here. So I've seen this presentation probably half a dozen times,
Yeah,
but
I know.
I do have some concern, some questions about it. For one, the difference in the way these work are that you apply, we don't get the money. Is that correct?
Correct, it's a drawdown.
And so we draw it down and we have to prove. So next year, if we wouldn't do a good job in whatever we were spending the money on, then there is a possibility that we wouldn't get that much money in the previous, or in the next year?
It's correct. Mm-hmm.
Okay.
They're very clear on that, uh-huh.
So I've just, when you say you're very confident that we're going to get that much money then next year, I understand, but there are some variables there that we may not have control over.
There are, I would just say the reason I feel more positive than not is because of the rigorous meetings and this time frame we have to meet with CMS on budget, on reporting, our project manager every 2 weeks. Not only will we have eyeballs on, hey, that spend's not going down, or they're not progressing like we thought on X project, right? Because they're not all the projects of KDHE or KDADS, right? They're farmed out to others that get the money. CMS is going to call us out concurrently. It's not going to be like, oh, we're at the end of the reporting and we're seeing you didn't make it. So we're going to know that. And I think course correction and intervention will happen early on. So yeah, not to sound overconfident, but I'm very confident that Kansas has a good process going into this. And so I don't want to mislead, for one, and I understand totally. But if it's not sustainable, CMS, this is what this is based on. This is not so like you go 5 years and then you end it, right? This is so that you've gotten the bottom line of a rural hospital, or you've gotten a clinic, an FQHC, whatever, or a PACE program instituted that, or a more behavioral health services that lowered the cost of care because they put telehealth in instead of having everybody go to the ER and have a crisis, like the circle we're in with patients and access to care today. So the hope is that it does transform, it leads to better outcomes, it leads to more efficiencies, less cost of care, et cetera. So, but I understand your point. Thank you.
Representative Carpenter?
So there are clear set of guidelines of the outcomes that they're expecting?
There sure are. And in the application, we need another whole day for us to go through. You will see, though, for each of these high-level initiatives, then there's a bucket. And then every single initiative is laid out, what's going to happen in what quarter, how we're going to do it, who's on point to do it, et cetera. And all of those are outlined in that document. And I don't know if you were able to peek at that, Chairman, but it's probably 30 pages long, and it's all in a spreadsheet that lays it out. It's readable, but yes, everything, all our metrics and measurements are there, and that is what CMS is going to go back and judge us on related to how we're executing.
One more.
That's fine.
I know, I had, so, you know, I've always struggled with this, with the CCBHCs and being able to measure data. You know, I feel like, you know, that was the big thing that got me over the top with CCBH, and it's been really slow in coming, and believe me, Kyle Kessler knows that I am not happy about that. But, you know, you just fling a bunch of money against that wall there, and in mental health issues and even substance abuse, same way, you know, the recidivism, I never can say it, you know what I mean? All that kind of stuff. So are we going to be measured for that? I mean, it's very hard to measure some of these, and maybe those aren't programs that are in there, but some of the stuff is really hard to see if you've made a difference. And that's my biggest concern, is that there may be unrealistic expectations in that. I'm done, Mr. Chairman. We'll have conversation.
Representative Ballard, do you have a question? Representative Ballard.
Thank you. I will just follow up on it. I understand what Representative Carpenter is saying, but I want to ask another question to maybe assure him in many ways. When you got the proposal and you were working on the proposal, there was a long list of everything that you had to fill out that really said your agency was qualified in order to do this. Am I correct?
That's,
And you had to give all of the information in terms of how you felt you were equipped, who you had to do it, what credentials these people had that would ensure them of doing that.
yes.
So then after that, they made, the guidelines would indicate the timeline when it was. And since you had indicated, and when you signed your signature as the principal on it, it said that you would verify that this was in all truth and honesty.
Yes,
that this would happen.
Right, yes.
So your guidelines meet with that, and that you have the people in order to do this, which says in many ways you're likely to be renewed as long as you follow those guidelines with the people you said you had.
That's correct. Yeah, and again,
I want to add to it.
yeah, I just say there's way more guardrails around this than your average grant, in my opinion. So,
Representative Carpenter.
Thank you, Mr. Chair, for indulging me. I wouldn't even had a question, but I'm showing off for my wife, who is in the audience. So.
Well, and may I say, I'm trying to plead his case so that she understands.
All right. Representative Oropesa.
Well, my question is does the Kansas Rural Health Innovation Alliance, they still meet?
Yes.
Will they continue to meet out of this process?
oh, yes, and it's ongoing. In their letter of commitment, so to speak, it outlines what their role is. They're expected to attend meetings. They are expected to help do interventions. So say a CCBHC as part of one of the initiatives, or a mental health or a hospital, that organization would help us get, maybe, first of all, help them, but also if there's non-compliance, how do we get them on board, or how do we engage them if we wanted to engage? So we're using them in that way. The meetings we've had to date are also, and all the PowerPoints and meeting dates are on our website. Those are also subject to, I forget the name of that, where it's public forum, public square. So they're all posted, and people can jump on those and listen as well, but the participants are the RHIA. We had the last meeting right before we submitted, I believe, the budget revisions. We were waiting to hear back about getting the money and so forth, and then we will reconvene them either via a WebEx or another in-person meeting.
So I have two questions,
Representative
if
Oropesa.
you don't mind.
Go ahead. I get my turn.
Yeah. Is this a set committee, or can it be changed?
Set as far as,
Members? Member
The
wise?
members, the governor appoints the members.
Okay,
If someone wanted to join, I would go through their office too. Yes.
okay, perfect. Thank you. Thank you, Mr. Chair.
Any other questions? Representative Rivas?
Sorry, I had to be at a
Oh.
hearing on another bill, so.
It's okay.
So I'm not sure if I'm out of context on this, we can
okay.
talk about it later. I was asked by some people involved with EMS services about this because they understand there's nothing in this with emergency medical services as far as ambulance, those kind of things. It's more about healthcare facilities. So is there any component of this with EMS?
There's a large transport and non-transport component. If you find out or want to tell me who that is, we'll be glad to educate them. It's online. You can see all of the initiatives.
I just heard that
Yes.
2 days ago, so I wanted to follow.
Yes, and I would just say this about the initiatives, if you don't, and then you can answer your question. The initiatives that were put in this plan were based on, not that alliance, even though some of those members were cross. A call was put out to say, show us your ideas for the application. We then, KHI, Kansas Health Institute, held a convening for us, got everybody together, we scored everything, and there was a lot of alignment on initiatives. So I'll just say that, from all the disparate healthcare delivery people and anybody that delivers care, any of those organizations, right? Transport, loud and clear, non-emergent and emergent. So yes, big component. So I would just say that was one of the big ones that aligned for everyone. So that workforce, the usual, right?
Okay, I'm looking around the room. You're smiling. Go ahead. Representative King, no, go ahead.
You mentioned a project manager. Is that project manager in-house, or did you go outside to a third party for that project management help?
We, to set up our infrastructure, we have a 10-week engagement going on right now with a third-party consultant. We also are engaging with a fiscal agent, and the grant will pay for these things. The fiscal agent, because of the rigorous reporting, and there are organizations out there that do this. Kind of, I think the state used a model like this, but it's not the same model or same firm during ARPA, which I came midway through. And
That's another.
it's a third, so that's a third party, yes.
Okay,
Yes.
do you remember the name of the third party to help you with this 10-week engagement?
Yes, BCG is the third-party consultant, and BDO, who is also just converted from a Horn, they're more known as. They already have a state present with, they do some work for the Corporate Commission, and then they're known across the country. They're an accounting firm, basically, but that's who we're going to use. My director will be the director of the program, and then we hire a project manager under him. And then the Care Collaborative reference, they're doing some of the project management for us, because a lot of what they do already in the region, in the rural areas, the Care Collaborative component of KU, they already have projects that are ongoing that they'll expand upon.
I promise no more questions, Mr. Chair.
I hope I'm not giving you a headache.
All right, so is it my turn now? Okay. So Janet, thank you again for doing this. I think this is the second or third time I've heard you talk about it, and I come away with additional questions every time I hear this. And so I would put this under the header of, can we go fast enough? And can our existing agency structure, which sometime is very, and I'm going to say I felt this way in my Navy career when I worked with the Defense Logistics Agency, very much the agencies cannot move fast enough. I think this is a cool opportunity to do all this stuff. So if you put that big header on, can we do this fast enough? And I'm going to rapid fire some stuff. Please don't answer these, because this is my thought process and development. Food is medicine. Is legislation going to be required? Will that be tied into Medicaid? Yes or no? Examples are the quarterly based payments to hospitals for employing evidence-based practices. Have we seen evidence-based practices working? I'm just curious as to whether or not and as you're getting closer to reporting, that those things are actually going to happen. I'm curious if there's an anchor hospital in my hometown of Great Bend. What concerns you the most? Is there a point of contact at CMS that the project manager has to interface with? And again, so I'm thinking of all these things under, can we go fast enough as a government? And if the underlier of that is transforming the delivery system, probably, after I've spouted all that, it comes down to the one question: what concerns you the most, and can we really go fast enough? Because we heard a bunch of questions. This is a tremendous opportunity. I'm more than pleased that you're running this. I thank you for the update, but the answers to those questions depend on, I think, what then can we do as a legislature to assist you and not get in your way once we get 2, 3, 4, 5 years out. So I don't know if that makes sense to you. It makes sense in my head.
It doesn't. I know you don't want me to answer, but I could answer a couple quick ones if you want.
Okay.
Speed to execution absolutely is key to this. And shovel-ready projects, and go back to my comment on expanding things that are already in place and extrapolating them out to areas that haven't had it. That's why we're doing that. We don't want to go out and
So that counts, so to speak.
Yes, because
Okay.
we did not want to go out, because that would be perhaps requiring new legislation, et cetera. Food is medicine. If we were already looking at that in Medicaid, one thing is, if we pay for food and medicine training and whatnot with these funds, we can't double bill for a Medicaid. You can't supplant funding that exists. So, and you made another comment related to, are there incentive-based programs? Yes, there are already. There's demonstrated proof that accountable care works. And one of our goals, and CMS was on the phone with us today, and they again are applauding us for wanting to expand accountable care throughout the rural health region because they know it works.
So is there just one down-to-earth example you can share of that? Because I want to
The Care
help.
Collaborative, I would have to get Dr. Mosher's, like, their data, but yes, I could
Okay.
show you that from the Care Collaborative, what they've done, and also improving outcomes through the Heart and Stroke Initiative, for example.
Okay.
They would be in a much better position to speak to that, but yeah, it absolutely works. Back to our person at CMS, we have a dedicated project manager. She is in the Baltimore office. However, her number 2, who we met today, is from Lawrence, Kansas, and just moved. And she keeps her house there. She was a physical therapist. She did work with the Haskell Nation on setting up a PT program. She knows Kansas. She's very excited to be on our account. The deputy secretary of this program for CMS in total is from Wichita, Kansas. She was on our call today. She is hiring a bunch of people to work under her, but she's a PhD, very well-spoken, did a lot of research on rural and accountable care and whatnot. We do meet with them. We will meet with them, and I talked a little bit about the mandatory meetings. We will meet every 2 months with them, but then have ongoing conversations, whether it be about budget, clarification on an initiative. It's kind of a mother may I thing. I mean, we just won't willy-nilly. We have to ask them a lot of I forget the term they used today, approvals. So we do have that. Am I concerned about speed to execute? Sure I am. If we manage it, though, and can catch those places where we're not, or we're falling down, or we say, this was a boondoggle, this one isn't going to work, hey, CMS, can we replace it with XYZ? It's just got to be ongoing. So I started my conversation because I feel strongly about this because I've executed a lot of projects in my career being in hospitals. If you don't set up on the front end, the process and the infrastructure and the governance, that's where your risk is. I feel more confident because we've set all of that up. Realize we haven't started in earnest, but we will. We will get this going, and then I guess time will tell, but that's probably my worry. But I don't have the worries you'd think because we have been literally at this since July, just trying to get things set up, understanding what CMS is doing. We got the award. Our application got glowing reviews from CMS, so now we don't want it to look, well, you have this application, you're not doing anything. It doesn't allow for that, to Representative Ballard's point. It doesn't allow for it. So.
Representative Carpenter.
Thank you, Mr. Chair. I'm still showing off from my wife. But, you know, there's been a lot of talk, I've talked to you about, there's a lot of talk about REH hospitals. And I have, and for some reason, I'm not sure why, I just haven't had time to look at your web link and I think I might have a little more time after today. But could you elaborate a little bit on what your plans are for the rural emergency hospitals and rural hospitals in general? I mean, I've said, you know, we blew through our ARPA money, and you can see some, you know, if you look down the list, there's some good things that it went to, but by and large, it went 25 million here and 50, you know what I mean? And I'm really concerned about this not having, you know, a generational effect and a generational chance for us to really beef up our rural hospitals so that they're sustainable.
Right.
And so could you kind of visit about how this is going, what your plans are for rural hospitals in this?
Yes, and I just say, if you want a one-on-one about detailed initiatives, we're happy to meet with anybody. So I'll just leave that out there, because I don't expect you to go read, you know, 500 pages. But with the rural hospitals, the capital investment grant I talked about is, for year one, is 15 million. There's a call out right in there. Part of that is to provide technical assistance to help hospitals that want to convert, that haven't been able to. It can also be allowed to help them with any capital needs to renovate. You know, there's a lot of these CMS requirements. You know, we get the fire marshal involved, you know, the whole thing that CMS requires, you know that, in the right room size, exits, whatever. The REH requires some of that as well. So there's a component in this is to help hospitals that want to convert but haven't been able to because of barriers such as facilities, or they don't have anybody that knows how to, or can't take a resource to apply and meet the CMS requirements, even to get the application in to convert. There's a component built in for this. So that's one thing with the REH. One call out for CMS, from CMS on this, is right sizing rural health care. And I say it with all due respect, I worked in 2 critical access hospitals in different states in my career. And there are a lot of people that don't understand the importance of them, but then there's also this camp of, does everyone need a full service hospital? You're aware of that. And so how do you say that without insulting anybody, or, you know, but there are opportunities for efficiency. So CMS also calls out the fact that they want people to work together. So some of the initiatives on the competitive pool of that 44 million, one of the criteria is, tell us who you're partnering with. Are you partnering with the FQHC if you're applying and you're a hospital, or are you applying, you know, if a service organization wants to apply for an initiative? Who else do you need to partner with? And so partnership and helping that way to right size or right define a rural hospital, for example, might be an outcome of this. It's a goal of CMS, I can tell you that. REH is a goal of CMS as well, but also coming to a conclusion of who needs what services and where, and how can you get them through a transformed model and still meet the needs for access and care and quality, and getting people emergency services, to your question. All of that's impacting. Throughout those 5 buckets, behavioral health impacts, as you know, all hospitals, right? The acute care hospitals are not all equipped to take, even the ones that are equipped to take care of behavioral health patients can't keep up with the demand. And so what can we do different there? What services can we provide? It all goes down to, bottom line, at the end of the day, if you've got people taking up beds that you're not getting paid for, you don't have a psychiatrist or someone to treat them, what are we going to do to transform to get them to the right care setting? So I could go on about this because my background's hospitals, and I don't want to bore you, but I can assure you that was all considered in this, and it's outlined in the plan.
Follow up, Mr. So you were saying a $15 million grant?
For year one, there's a $44 million competitive pool. It's called the partnership grant component for year one, and $15 million for capital investments. One of the reasons it's only $15 million for year one is because CMS capped everything. You can only use this much for administrative. You can only use this much for capital investment. So out of our total pool, we had to get very creative about what % we were going to say could be capital and what we could use it for. Again, every time I tell you something, I feel like I'm going down a rabbit hole, and I don't want to do that to you. But that's why it's capped for year one at 15. Yes.
Well, thank you for that. What I do know is it was about a $5 million, we backfilled about a $5 million deal for our REH hospitals that we have now, the 3 of them, to get them over to fee-for-services, if you remember that. Mm-hmm. So when I see that, 15 million is only 3 hospitals.
And I hope if you ask me what else I'm concerned about, I'm hoping that even with technical assistance, people do want to participate in some of these programs, but I can tell you because the rural healthcare providers are strapped and they're doing the next, keep trying to do the next thing to keep up with the patients, and do they really have time to get into regulations and what? That's what we hope this grant can provide them, is some technical assistance to help them with that. So, yes, but it's year one, remember, this is year one. And those are, and just so you know, a conversion, as you probably know also for a rural emergency hospital, because we don't control that. Once the application's in, KDHE facilitates that with CMS and makes sure that, paperwork's in and whatever, then it goes on the pregnant pause of CMS's timeline, right? We wait and we wait and we wait. And we hope that they won't do this and that they, again, say they're open to things. So I'd like to think it's going to be more positive, that they will realize, hey, this isn't the RHTP. We've got to get these REHs turned around because this is part of the premise of the grant to begin with. So I'm going to remain optimistic that they'll be better. But I'm not as worried about that amount of money just because it goes on. It's ongoing, and sustainability being the factor behind it.
Thank you for that. I know we got a little deeper than.
Well, I didn't mean to get so deep, sorry.
I don't know if there's any other, I do appreciate the depth. Every time I hear you speak about this, and again, I try to get into that, okay, how at some point are we going to be working in parallel with, just what we've come through together to some degree. We've done our part of the budgeting process. This is kind of working, maybe not tied in parallel, but at the same time with that project. At some point, they're going to come together.
Yes. You asked about what you could do and what, to help. And so I think we all have a good rapport with the legislature, so and we're not shy to come and ask and try to advise. We have a whole project plan where we parsed out anything that's going to need a policy change, a statutory change. There's not a ton, but there's some that might, okay? Some might be Medicaid changes that you all need to approve through caseloads. There could be some of that stuff. That's where we're going to need your help. And if you don't help, it puts some of it at risk because CMS, we didn't check every box, and there's some opportunities we have to get a couple more box checks, but we have to change a few regs here and there. So I think listening to us and collaborating with us on that. And the other place might be if we have an initiative that requires not just KDADS, KDHE, might I'll just say Department of Transportation, or it could be a stakeholder organization that we need help with, because we need them to help us, and maybe we're not getting that support or can't get a meeting, or, there could be a number of things. We haven't run into that, but I can see where things like that, so you understand the whole picture and help us put together that whole picture. That would be great.
Okay, perfect. Thank you. Representative Ballard?
Thank you, Mr. Chairman. When you were speaking about you could partner with whomever you choose, that would strengthen your program, would that also include, could one county, then could they pull in another county?
Absolutely, that's the hope. And if I can go one more deep, we have a decentralized local health department model. KDHE helps with technical assistance, but we do not run them, and nor do we say we want to. However, there are health departments out there that maybe have 1 and 2 people, or they're short-staffed, or they can't do all the services for WIC and all that other stuff that maybe a larger one would. Could there be a model where health departments look to each other and say, and some of this might be, what are you going to give up to get ahead, right? Nobody wants to give up anything up. And I'm not even talking about money. I'm talking about identity, services you provide, whatever. However, at some point, maybe if you're not doing a great job or can't do it, maybe it's time to, look inward and say, maybe this would be better if we did outsource or go to another county or collaborate and partner, share a nurse practitioner, share some other service, So there's a bunch of opportunities like that as well. So yes.
I really appreciate that, because if it was all, let's just say if Douglas County was part of it, which was my county, and all my partners were within Douglas County, it's not expanding it. But if you have other rural communities that are smaller and they're with another one, then everybody sort of benefits from what they have, and they all get to experience more growth and have better health.
Correct.
That's
And
why I was
maybe,
asking about that.
yes, and maybe more specialty care and that type of thing. So there's opportunities, so.
Thank you, Madam Chair. Thank you, Chair.
All right, folks. If I don't see any other questions, Representative Rivas. Sure.
Thank you, Chair. This is a little more of a observation, I guess.
Okay.
So this is a big thing, and there's a lot going on. There's a lot of activities going to be expected out of all these rural areas. So a lot of people are resistant to change typically, and there's a lot of, we do it this way, it's always worked for us and all that. So from your view right now, this feels like a lot of top down. It came from DC, it's coming from Topeka, and it's going to these rural counties. So what's been your feedback so far? People seem pretty accepting of the idea of getting on board with this and trying to figure it out. Are there barriers to getting buy-in?
No, very accepting. Kansas Hospital Association being, I mean, I say it's not all about hospitals, but let's face it, things start with, right, hospitals touch everybody, right? And so they have been very helpful related to conveying to their members and hearing from their members, what can I do? When can I start? And the Care Collaborative being out there, the KU, University of Kansas, I mentioned earlier, I don't know if you heard, big partner for us with this. They're already out there, Dr. Bob Mosier and Dr. Jody Schmidt, and Marty Ross, who's been out there doing this kind of work for over 10 years. I asked a similar question related to some of the initiatives when we were building the application related to some of the and they said, no, absolutely, people want to do this stuff, Janet. They're looking for answers, and I think we have not run into any barriers. I would hope it's not as top-down as it might appear. Issuing the money might be, but we've built this, and some of the to get around barriers too. A lot of this will be sub-recipient grants, so we will give the money and then others will run their own program. We just have to monitor it, but they will be responsible for running their initiative, which empowers them. I mean, so it's not as top-down as it might appear. Mm-hmm.
All right, one last chance, folks. Representative King for the
final time. And I'm showing off to Mrs. Wilcott now, too. Mrs. Carpenter, I'm sorry. So it's not on the front page of the KDHE website, but I got some help to find it. It's not clear as to where the budget's at, so if you could send the link. I'm on page 75 of the 134-page document, and that's where the budget starts. And that is, and I'm just under this one section, and there's one line item for $34 million. And then the following pages after that kind of break it down. And then there's $7 million for integrated behavioral health training. So that's the least detail that I think we're going to find. So there will be $7 million line items that.
There's more detail to that, though.
To
Just
that
there's,
seven.
in that the spreadsheet where I said Q1 we're doing this and all of that, that is all explained in detail. And if again, I will offer our services to come and cross-reference the grant to where the budget is, to where it lays all of that out. We could not just submit that. CMS needed to know every step of the way what that meant, who was going to do it, what does that even mean? In the training piece especially, so happy to help with that. If you
That would be worth, Mr. Chair, going through, because what we're going to be able to see is that's the level of detail. We're not going to be able to see the other detail.
we could offer that on a Zoom if anybody wanted to do a WebEx or in person. I mean, maybe give us some feedback on how we could be more helpful with that. Okay.
Yeah.
Thank you.
And I don't want to go down a rabbit hole. This is not intended to be a rabbit hole, but one of the things that came up in appropriations today was, are there duplication of efforts? I mean, either through some of our provisos or any other, so let's use mental health. We're trying to think how it was put. We need to just make sure that we're not duplicating or providing duplicate services that would have otherwise been part of a state agency budget. So just, I guess, park that as a comment that was made and something that's
It's not a rabbit hole. We have a whole initiative on cross-checking duplication, because I think I mentioned earlier what CMS calls it is you cannot supplant.
okay.
And so that's the safeguard there. So we would never have done that. We're cross-checking, and I mentioned earlier that was for community health worker. Let me just, quick example, not a rabbit hole. The Medicaid program pays for some of them already. You can bill a code to pay for this, this a very important healthcare provider to helps the providers do some of the things that take them away from the caregiving unit, right? If you find that you have a community health worker that's already being paid by Medicaid, but yeah, and you put them in the food and medicine program, and now they're going to get paid through the fund, can't do it. So it's an automatic, no, you cannot do that. So we are cross-checking duplication and whatnot. So good point, but CMS loud and clear, you cannot duplicate. So
Okay.
payment for docs, payment for other providers, APRNs, whatever it is, you cannot do both. It's one or the other, so.
Appreciate it. Okay, committee, we're going to call it a day.
Well, thank you.
Thank you and the team for being
I'm
here.
excited because I'm
No,
excited
this-
about launching it with everyone. We have such great partners on this, and it's a state effort. It's not just the state. It's
This-
around the state,
This
so.
is exciting. Thank you.
Thank you very much. Good seeing you all.
All right, committee, we're calling it a wrap. Thanks.